The accuracy of the test is a very critical issue. What does it mean, accuracy? The accuracy is the ability of the test to reproduce the same results if you repeat the analysis. So it means that really the tests give the information that is in some way precise and reproducible across different analyses done in different time and on different samples. Lack of reproducibility of a test make the same sample to be assigned to different risk category that can mislead the indication, because it can have some reflect of the biology, like the tumor heterogeneity that we sometimes count out in the tumor, but the majority of the time is just the technical issue. So the accuracy is usually validated in a specific paper that look how the test perform in repeated assessment on the same sample in different time, in different lab, or in the same central lab, repeated in different conditions. And this is the basic assumption for the use in the clinic of any test. So without a good accuracy, the test is not considered suitable for clinical application. It is related to when we consider a test that is fully validated. There was some very old guidelines that define when the test reach the level 1 of evidence that require a prospective evaluation of the test. Recently, this guideline has been revised by a very important work published by Richard Simon on JNCI that describe how using clinical trial which are performed in a prospective way, but looking at the biomarker in some way in a retrospective way, because we put the question about how the biomarker perform after the trial is concluded, but in a completely independent way according to the results. And this trial can provide a level 1 of evidence. So when a test can be used in the clinic, when we trust the data that we have reached in some way a level 1 of evidence in a prospective trial, or a design that is called prospective retrospective, so using prospective design trial in a retrospective way as I described, and demonstrated that the test is able to make an actionable prediction. So it's not enough that the test is prognostic or the test is predictive, but the prognostic value should have a clinical value. For instance, in breast cancer, it's not enough to have a low risk, but the risk should be low enough to spare safely the patient from addition of the chemo, if this is the purpose of the test.